Welcome to Voice for Infection Prevention, where we explore the latest developments, challenges, and insights in the field of infection prevention and control. With a passion for promoting patient safety and healthcare excellence, we're excited to bring you engaging discussions with experts, leaders, and innovators in the field. So whether you're a seasoned professional or just beginning your journey in infection prevention, welcome to the conversation. This is Voice for Infection Prevention.
Welcome back to Voice for Infection Prevention. Today I'm joined with an incredible leader in the field, Melissa Bronstein, whose career journey showcases just how dynamic and evolving infection prevention has become. Melissa's path started in quality control nursing, but a chance assignment to an infection control training course completely changed her career trajectory. Since then, she's built an impressive resume working in academic medical centers, community hospitals, and now system-wide leadership as the VP overseeing infection prevention across a healthcare system. In this conversation, we dive into how the role of infection prevention has expanded over the years, moving beyond just hand hygiene and isolation to include construction, air quality, environmental hygiene, and complex regulatory compliance. Melissa shares her insights on career progression, mentorship, and how infection preventionists can advocate for leadership support in their organizations. We also discuss the lasting impact of COVID-19 on the profession and how infection preventionists can maintain their influence in hospital leadership now that the crisis has passed. If you're looking for career advice, leadership insights, or a fresh perspective on the future of infection prevention, this is an episode you won't want to miss. Let's get started.
This episode is sponsored by Clutch Recruitment, the leading recruiting firm in the country, recruiting exclusively within infection prevention and control.
All right. So to get started, I was looking back. I think our first interaction was back in 2015, and I was trying to rack my brain because I remembered you had a pretty interesting, not really an interesting background, but at the time you were working at a middle school, if I remember right, and then we're pursuing leadership positions. So I'm definitely going to ask about kind of how that happened, because you propelled your career phenomenally after kind of a gap. So I want to get into that at some point. But first, the first question I have, and I ask this to everybody, but it's, how did you end up really discovering infection prevention? Like, how did you get into the field to begin with, and when were you exposed to that?
Yeah, well, like so many people, I did not really set out to be in infection prevention at all. All I knew about infection prevention, honestly, before I got into the field, was when I worked at a hospital in New York City. There was one woman who walked around, Mrs. Ebert, and she would make sure patients were on isolation, and she would advise about antibiotics. And it was like I just didn't know really what she did at all. Did not appreciate, the depth and the extent of the work that she did. And, didn't really think about Mrs. Ebert for a long time after that. And then when I moved to North Carolina, I was trying to balance graduate school with nursing. And so I took a job in the quality department to be a quality control nurse. Back in the day, that's what they were called. And I was on the job maybe 2 months, and the director of the quality department came in and said, "We're taking over infection control," is what it was called at the time.
Okay.
So we are going to draw straws to see who is going to go to the University of North Carolina week-long course to learn to be an infection control nurse. And I literally drew the short straw and went to UNC for a week. And my teachers were Bill Rotella, Karen Hoffman, Dr. David Weber.
Wow.
And I went in, and the first day of class, I realized this was what I was meant to do. This is exactly what I want to do. And I took that first course, part 1, in 1990. And I have been in infection prevention pretty much ever since. I did have a brief window of time where I got out of infection prevention, but it sounds like we're going to get back to that.
Yeah.
But yeah, I was lucky enough to have great instructors. Karen Hoffman. People will recognize her name as a past president of APIC.
Absolutely.
But she and Dr. Rotella and Dr. Weber, they started the SPICE program. That's the state program for infection control and epidemiology. It's sponsored through UNC, and it's a phenomenal program. And I was just lucky enough to be a part of that.
Wow.
So that's how I got into infection prevention and never left.
Wow. No, that's awesome. So tell me, I imagine infection prevention is probably looks totally different today than it did in 1990. So I'm curious, when you first stepped into the role, it feels like, especially now, when people get into it, they're surprised by how expansive infection prevention is. And there are things, I mean, construction's a common thing. I mean, there's things that you're exposed to that you just wouldn't probably expect in the role. Now you obviously had tremendous instructors and went to this class beforehand, but were there any surprises when you got into like the day-to-day work?
Yeah, just as you say, I think like most people, I thought about Mrs. Ebert, who I just saw her wandering around the units looking for people in isolation. I didn't realize all the other work. And I think that so many people, when they're getting into infection prevention now, it's still a little bit a surprise that the breadth of what an infection preventionist covers, the amount of ground that infection prevention participates in, from the environment to facilities to the air management, construction projects, sterile processing, the OR. I mean, we are literally everywhere. And I think that really was a surprise. So it's not just that we're everywhere, but also we know a great deal about. So it's wide, but it's also very deep. And so I think that was a very, very big surprise to me, and it can feel very overwhelming for a new IP. But yeah, the world of infection prevention is incredibly broad and deep.
Yeah. So now, at the time when you joined, I'm sure you had several other IPs at the facility, I imagine, or maybe people that went through the class with you. But was it predominantly nursing at the time?
Yeah, I would say almost 100% nursing.
Okay.
And I want to say that that first hospital is at Wake Medical Center in Raleigh, North Carolina. They're the ones who, blessed me with the opportunity to go learn from the experts at UNC. We were a department of 8 nurses, and it was an unusual construct because it was the quality infection prevention program, but every person did both quality and infection prevention. So we all did a little bit, but as the person who was trained, it was my job to sort of coordinate the program of the 8 different nurses. But yeah, as you said, in the 1990s, before that, and even for up until fairly recently, predominantly nurses were considered the only ones who could really be effective infection preventionists. But since then, I've been lucky enough to work with stellar microbiologists and stellar, master's of public health graduates. So everyone brings very different skills to the table and really can create a very strong and effective program.
Yeah, and it looks like you had probably 8 years or so as a nurse before you stepped into the quality infection prevention world. Was there a steep learning curve for you, or did your experience translate pretty well?
Well, nursing is, people talk about a nurse, but nurses are a different kind of nurses. So, yeah, I spent most of my career as an orthopedic nurse. I didn't have intensive care experience. I didn't work in pediatrics or neonatology. So, yeah, there's a little bit to learn. But, I've always said the key to a really successful infection preventionist is keeping that curiosity and that that ability to always ask, well, that's interesting, tell me more about that. It served me well when I was learning to be an infection preventionist, and it serves me well every day as I'm talking to people and trying to understand what's contributing to this phenomenon we're seeing, either high infection prevention rates, or an increased risk of infection prevention, a threat to infection prevention in the environment.
So, and just out of curiosity, obviously, if you were doing infection prevention and quality, that's obviously those are pretty separate now as far as responsibilities go.
Yeah.
But that feels like a whole lot I mean, was it a whole lot back then too?
Well, it was. I mean, it seems crazy now, but yeah, I can remember, doing chart reviews. And on the one hand, we'd be looking for, the positive urine cultures and do they have a Foley catheter? And oh, by the way, they also got transfused with 4 units. And did they meet our criteria for that as well? So it was an unusual model. I don't think you would see that. Um, but it's also important to remember that one of the biggest changes that I've seen in infection prevention over the 30 years I've been in this role is the amount of mandated elements that an infection prevention must do and must report on, and there's many eyes on it. So it used to be that the infection preventionist would do an assessment of where do we think our risk is? Do we think our biggest risk is CLABSI? Do we think our biggest risk is CAUTI? And you didn't necessarily focus on everything all at once. You could really pick and choose the things. So you could say, well, for this quarter, we're really going to focus on CLABSI and bloodstream infections. And next quarter, we're going to focus on, UTIs and CAUTI infections. You can't do that anymore because everything has to be monitored. The stakes are quite high for all these federally mandated infections. And so the work that an infection preventionist and an infection prevention program needs to focus on is pretty much decided outside of your own organization. So even if you don't have issues with high CLABSI rates or CAUTI rates, you still have to dedicate the time and resources to tracking that. You can't choose to let that go to focus on something that's more relevant for your facility right now. You're expected to do both, but of course, everything takes resources.
Yeah, and tell me, just out of curiosity, what do you remember what ratio, like staff to occupied bed ratio you had back then?
Oh my gosh. I want to say that the rule of thumb we used to use decades ago was 1 IP for 200 beds.
Okay.
And because I remember, when they put it down to 1 IP for 100 beds, that seemed like, wow, that would be great. That would be awesome. And now, because our responsibilities are even greater, I've read in the literature 1 IP for every 69 beds. So it's really the expectations from the infection preventions are much higher because of some of the, the federally required reporting. But in addition, we know more now than we did 30 years ago as well. The use of UV lights, that wasn't a thing. The use of alcohol hand rub wasn't a thing when I started in this. It was a huge, innovation. So yeah, it's a different job now, a very different kind of job. And in some ways, the job is much easier because we have better tools, we have better supplies. On the other hand, the expectations are much higher now also.
Did you see, and I'm jumping ahead a little bit, but did you see a change from expectations and resources once COVID hit just a few years ago? Or was it not as significant, like, I guess, looking back over your whole career?
Yeah. Well, shoot, COVID was very significant. I think what really stands out to me about COVID is that during the pandemic, all eyes, all attention was on infection prevention. We were pulled into almost every single conversation, and people were very concerned. People really looked to infection preventionists for guidance. I would have to say, since then, the thoughts around how we manage infections has really changed. I mean, everyone knows the politics around vaccines, and even masking has become, that very basic control method we've been using for decades to control the spread of infection has become politicized. And I think that's something that we really need to navigate well. Is to convince people that, what we do, the PPE that we wear really does make a difference. It really does make a difference. Yeah. And I think everyone has seen that the CDC posted an announcement that most of the gains in reducing HAI rates prior to the pandemic So many hospitals saw increased HAI rates during the pandemic and are, now in 2024, just getting back to where we were. Um, it takes a lot of effort and a lot of concentration to sort of unwind some of those bad habits that were
Yeah.
developed during the pandemic. So yeah, I mean, COVID was on the one hand, uh, pressure is a privilege. And sometimes, it was, it felt good to be the source of information and bringing evidence to conversations about what to do during the pandemic. But now we have to keep pushing on those skills to be sure that we're getting back to, effective habits around device maintenance, device selection, and how we're preventing HAIs again.
Gotcha. And then do you see, and just sticking with the pandemic here, um, has that kind of shift in not priority, but I mean, you're saying you were called into every meeting and now all of a sudden you were like relied on as a resource for
Mhm.
so many things. Has that stuck or have you seen that start to calm down as well?
No, I mean, I think we're still called in, and again, I think that individuals working in healthcare who value evidence-based practices, they still, pay close attention to our recommendations, may ask questions, but that's all good. We love questions.
Yeah.
So yeah, I mean, I think some of the unwinding is more about individuals at the bedside who just need to be reminded of those best practices because, we're 5 years after the start of the pandemic. So many people started their healthcare career during the pandemic. And so we just want to be sure that the lessons that they may have picked up while they've been working on the units since they started really follow those good evidence-based practices. Because
Yeah.
sometimes people, what they've always done, we can probably tweak it and do it better.
Yeah. Yeah. Okay. And taking a step back, so you were at you're at WakeMed for a
Yeah,
couple of years, it looks like, and then made the swap to Duke, so another North Carolina hospital there, another
yep,
academic facility. Um, I want to ask you, they gave you a nurse epidemiologist title,
yeah.
um, which is fairly uncommon today, at least. But I'm curious, that was your first time changing hospital facilities once you got into the infection prevention role. So how big of a deal was that for you? I mean, obviously, you had just learned it, you had done it for a while, probably just got into your groove of kind of feeling like you knew what was going on, and then swapped to a new facility. So I'm curious, did that all translate well, or was it a totally different experience when you moved systems, or what was that like?
Yeah, so when I moved to Duke, I was recruited to come to Duke University Medical Center. And, the skills that you learned as an IP, they're transferable anywhere. And one of the things I know for sure is that whether you work at a small community hospital or a large academic medical center, the problems are the same. It's just sort of a sense of scale. So the issues that we dealt with at Wake, I mean, Wake was not a small place by any means, but Duke was even bigger. Uh, but the same methods that are going to be effective, the same evidence-based practices that we put in place at Wake to resolve issues, we could definitely put in place at Duke. Sometimes you had to tweak around the edges, but the same principles apply. The the reason I had the epidemiologist role at Duke was I had the opportunity working while I was there. I was working with Dan Sexton, Kathy Kirkland, Keith Kay, and we were very focused on publishing and having the data to support the statements that we were trying to make and to be able to demonstrate the effectiveness of our program. And so I had the opportunity to learn about creating a database, about the importance of gathering your information so you had sound numerator and denominator data. And so I really got very deep into managing the data and doing the statistical tests and analysis to be sure that the changes that we were seeing were really statistically significant. So it was sort of the same work, but I just added this new component of trying to look at the data and be able to demonstrate the efficacy of our programs and our approaches.
And then did you have to learn all the data like the data side of the job, like on the spot? Because I mean,
Yeah,
I can't
yeah.
imagine you were trained for that in nursing
I was
school.
not trained for that, and how I got into it was just, again, this was pre-internet. This was you couldn't Google how to do things. So I had a book. I had this big fat, Learn Access 95. So Microsoft Access was our database that we used for everything. I mean, even Excel didn't do the kinds of stuff that it can do now. Now Excel looks a little bit like Access did back in the day. But yeah, and it was terrific fun. And Dr. Sexton was just a great encourager and a supporter of me gaining these skills and learning to do some of these functions. And it was lots of fun. But yeah, I would be up at midnight, 1 o'clock, trying to figure out why my queries weren't working.
Goodness. So, all right, from there, then, all right. I think this is about the time you at least finished up your graduate school. Is that right? You went and got a
No,
master's.
hadn't started graduate school yet.
Okay. Okay.
Went to I should say when I came to North Carolina, I was in graduate school for a nursing executive degree. But then I decided with my new love of infection prevention, that wasn't the degree that was really going to help me.
Okay.
And so I put graduate school on hold. And then things with my family, we moved across the country. So we left North Carolina, we moved to North Dakota, was in North Dakota very briefly, and then moved to Washington State. And in Washington State, I was in a small town in the southeast corner of the state, Walla Walla. Here's to you, Walla Walla. Go sweet onions. And while I was there, I could not find work in infection prevention at all. And by then, I was halfway through my new degree, which was a Master's of Public Administration with a concentration in health policy, which I really did enjoy. And I had started that program while I was in North Dakota. But in Walla Walla, I
Gotcha.
couldn't find work as an infection preventionist or an epidemiologist. And so I started working as a school nurse. And boy, the students at the middle school where I worked got more education about the importance of hand hygiene, the importance of vaccination. These kids really knew, the basic principles of infection prevention.
Goodness. Well, if anybody needs it, it's probably middle school boys. So
Good
that's
point.
that's good. No, so okay. So you're doing the school nurse, and you said you couldn't find any jobs. Was that because, I mean, just the jobs in general were limited, or were people still trying to figure out what infection prevention was
Yeah.
out west, or what do you think contributed to that?
Well, when you leave the big city of Raleigh and you leave, the big town of Durham, North Carolina, with a big university, and you go to a small rural town, there were two small hospitals in town. That was it. And the next big town over was 100 miles away. So your options are limited. But I did do some, work. Sort of volunteer, I guess, or just stayed in touch with the infection prevention teams at the hospitals in town. But there just wasn't work for me. So it was just funny timing. That's all.
Okay. And then, like most people have experienced, I mean, to progress and grow in your career, just with the limited amount of jobs there are, you typically have to relocate in order to advance. Like it's rare that you're able to get promoted within the same system, and you have. So we'll get into that in a second. But most people don't, either don't have the patience to do that, or just don't have the opportunity to do it. So you ended up moving to New York and landing a manager job initially. Did you relocate for that job, or did you end up in New York for personal reasons and then that job opened up?
So it was, it was like Kismet. I was looking to leave the West Coast and get back to New York State. My brother happened to live in Rochester, New York, and said, "You should move to Rochester." And I was like, what am I going to do in Rochester, New York? Because I really didn't know anything about it except that he liked living there. But then, I go online and the University of Rochester is looking for an infection preventionist. So again, my lucky star came up, and Anne Marie Pettis is looking for an infection preventionist to come there. And actually, when I first got to the U of R, I wasn't the manager. I was hired in as a
Oh,
infection preventionist. So I was working under the manager at the time, who was a great IP, and Anne Marie Pettis was the director for the U of R system. And I was there 1 year, and because of a lot of crazy experiences, most of the department went in different directions. So, and as I said, I had been a school nurse, but when I went to U of R, did my basic IP work for the first year, and then now the manager position is available. And so I applied for that, and Anne Marie put me in that role, and I was the manager for the U of R program for an additional 5 years. And then I was recruited to the health system across town, Rochester Regional Health. So in 2016, I finally bid adieu to U of R, came across town, and was hired in as a system director, which again, we talked about going from a smaller hospital, Wake Medical, to Duke. The difference in going from one or two hospitals to being over a system that's not just 8 acute care hospitals, but also 5 long-term care facilities, and not to mention the 500 ambulatory sites.
wow.
So the scope really changes, and the work of an infection preventionist changes when you're sitting in that position versus when you're at the desk trying to resolve CLABSI in your ICU.
Wow. So, all right, let's see. You came back. Let me ask this. And this is an interesting question, but I feel like, and maybe times were a little bit different at this point, but today, if you had 13, 15 years of infection prevention experience on a staff level, and especially with you, which we're kind of leading teams and doing different things in those staff positions too, it sounds like. But I'm just interested, you were willing to take a staff level role again. And I'm sure some of that had to do with you couldn't find work out west for a minute. So, but I think it says something about you that you were kind of willing to humble yourself a little bit to go back into a staff position. And I'm just curious your thoughts on that. Like, how would you today, would you recommend that people are willing to, I don't know, take a step down or go lateral versus just always pursuing the next step? Like, was that beneficial to you to kind of get your bearings again, or to see what it looked like on the floor before kind of working your way up again?
Yeah, I would have to say that, when I talk about I was a school nurse and I did that for almost 4 years. So I was out of infection prevention for 4 years. And in those 4 years, that's when federally mandated reporting came in. That's when the idea of, describing and identifying bundles around cloud, all that seemed to happen in that 4 years I was out of it. So for my purposes, it was actually a almost strategic move because I wanted to get back to infection prevention. But honestly, I didn't have the knowledge of what was going on, both at the local level nor at the federal level. I needed to give myself some time to, readjust and recalibrate, be sure that I was up to date on the definitions, because as everyone knows, those definitions change. And if you've got muscle memory from definitions from 5 years ago, you're not going to do well. So it was good for me, and it worked out, and it was a move that I wanted to make. So is it the right move for everyone all the time? I can't answer that question, but I think that there can be value in recognizing where your own gaps are in your knowledge and your experience, and maintaining that sense of curiosity that I mentioned earlier, to say, what are the skills that I need, and what's the best position that's going to help me get those skills so that my next move, I'm going to be more successful. If I had tried to, if a manager position had been available in 2010, which is when I made the move to University of Rochester, if it had been available and I had been in that role, I don't think I could have done well. because I would be trying to catch up with what are the federal requirements? What does CMS require? How is this structured? There would have been an awful lot of painful adjustments along the way. And being in a more highly visible position, that doesn't go well. That doesn't go well. So
Yeah.
I think for me, it was the right move, and I think being able to identify where one's own gaps are, and working towards improving them and working on them quickly, that's the way to be successful.
Um, and you mentioned this. Obviously, there's just so many changes within infection prevention every day, and I'm sure as you're working into it, it kind of becomes second nature, and you're just in it, and you're used to it. But with your experience, you were able to step out for a second, 3 or 4 years, and then
Mm-hmm.
come back in. Was it a night and day different job from when you left and came back? Like now that you weren't just like seeing the changes every day or every week, and then you just left it and came back. I'm sure that, I mean, you mentioned it. The things that were required between the time you left and came back
Yeah.
were just significant. But was it a totally different job?
It's not a totally different job. I mean, at the end of the day, the job is always what does the evidence say are the best practices in order to avoid this type of infection in this? And so the work that I needed to do was find out what does the most recent evidence say, and what are the expectations from the state and federal level. All that was the new part. But the basic work of identifying my resources, the CDC guidelines, APIC text, AORN, all the texts that we look for. I just needed to get back into that rhythm, see what changes had taken place, and be able to communicate that to the units. But the part where we go on the units and assess the environment, that hasn't changed. That hasn't changed much. I will have to say, though, that when I started, I don't think there was a good appreciation of the impact the environment can have on infection risk. It was just different. We really looked more at the hands of healthcare workers, and felt that was the primary source of contagion. That's still true, but it's also true that C. diff gets in the environment. It's true that highly resistant organisms can get in the environment. And so we need to be extremely careful about the selection of our disinfectants, the techniques we use with disinfectants, and if we have added components we can tie in with our cleaning and disinfection, such as the use of UV light, or hydrogen peroxide. These are things that we want to be sure we're taking advantage of also. And that's a real change.
And you mentioned once you kind of recalibrated, then you were able to kind of confidently go into a management level role. When you started that manager role, it's got to be different. But how big was that team? Like, how many people were you managing at the
So
time?
that team, we eventually got up to 7 people, but
Okay.
honestly, there were 2 people less in the department when I was hired as the manager. I switched to the manager, so we immediately hired 4 new IPs. And if when you train one IP, there's a lot of learning time. There's learning that needs to be done with the new IP. Studying the NHSN videos, for example. But there's a lot of shadowing and a lot of working with. But when you have 4 new IPs, you can't do all that one-on-one work. So I put in place different ways to do our work. So we were sort of learning together. So for example, during our HAI, we set up a weekly HAI review meeting. And that was an opportunity for the more experienced IP to present the case, to show where in the chart they were able to identify the elements that fit the definition, and then bring it to the group as I'm going to report this as a CAUTI because it met this, this, and this. And that that checked a lot of boxes. It helped the new IPs learn how to apply the definition. It taught them where to find those data points within the electronic medical record, which can be confusing if you're navigating the electronic medical record for the first time. And it also just gave us an opportunity to, sometimes you have to discuss the application of the definitions and make sure we're applying them appropriately. So things like that, where we could do things together, helped solidify the methods within each person, but it also gave us some time to build as a team as well.
Nice. And was it difficult to learn the I guess leadership ability necessary for that? Like I've talked to more and more IPs, and I think that's something that's a little bit undervalued, underappreciated early on in your career, and then you
Yeah.
kind of get thrown into a leadership role because you're the most experienced on the team, and you tend to be qualified for leadership very quickly in the infection prevention space, just because of how limited people are. So I'm just curious, did you feel like you were prepared as a leader, or did you really have to shore up and do different things to kind of grow your leadership ability?
Uh,
Or speak to that just for a second.
Yeah, I think that I think I was really lucky to have worked with phenomenal leaders. I think, for example, about Mary Oden and Dr. Dan Sexton, who I worked with at Duke. I think about Rosemary Thompson, who I worked with at Wake Medical Center, Mary Faye Beasley. I mean, these people are incredible, and they really modeled what a great leader looks like. Just like I do a lot of research around, the current evidence for preventing HAIs, I also did some reading about leadership. Had some authors that I enjoyed looking towards. I find the Harvard Business Review articles can be very helpful to think about how to lead a team. And so I think looking outside of infection prevention, lifting your head up from the work that we're doing in infection prevention and looking to see how do other people manage teams that have to both be technically savvy. We need to, know the nuts and bolts of, what are the recommendations we're going to make, but we also need to be good communicators because infection prevention is all about the art of influencing, right? Because we have authority over almost nobody. And so if we're going to do that, we need to be able to do that externally to our department. We need to be able to influence outside. We also need to be able to influence within our own staff and our own team.
And I'll say you quickly went. I mean, you went from manager, then senior director. Now you've got this VP title, which is awesome. And we might get to that. I don't know, but you've clearly moved up the ranks. I mean, there's not a ton of VP level positions in infection prevention across the country. It is trending that direction, so hopefully we see more of that. But you've mentioned more people really by name in this than anybody that I've spoken with at this point. So I'm gathering that mentorship and that sort of thing is something that you really valued throughout your career and something that really helped you. And so I'm curious, can you speak to how important that was for you in your career, and then also maybe how you're attempting to be that for either your staff or just the industry as a whole today?
Well, sure. Yeah. I mean, I think, being able to watch a great leader in action is the greatest gift you can have, and to be able to, retain those lessons. So yeah, I don't mean to be a name dropper, but I just feel like I've worked with such phenomenal people. I just want to make sure that I'm tooting their horn for them also.
Yeah.
But yeah, my VP position, I mean, I've been in sort of the same role while I've been with Rochester Regional Health. The responsibilities have expanded, but so much of infection prevention is really helping others in the C-suite see that breadth and depth of responsibility that we have. And I think sometimes the person who originally wrote the job description to say, we need someone to be the leader of infection prevention here, sometimes they don't really get all the things that we're doing. And so it's important for any infection preventionist to be able to advocate for the work that you're doing and be able to document that and be able to demonstrate the impact that your work is having on the organization. And so I was able to, write up and present the work that I had done, the work that I do with APIC, the work that I do in the community, and demonstrate that the work of this senior director infection preventionist is at the same level as the person you call the VP of, whatever department. We're doing the same level of work. And just opening their eyes and helping them see exactly what we are doing and the value that we do bring. I think it's really important. And I think you asked earlier about, how did COVID impact, the reputation of infection prevention? I think it brought it some good visibility. But I think it's also up to us to advocate for ourselves and to be able to help our senior and executive leader teams recognize that infection prevention is not just a subset of, another department. We really can be, a group that the value that we bring deserves its own merit.
Yeah. And no, and I think it's great. I think it's great that you're mentioning the names that you are. I mean, you've had some, very recognizable names in this profession that you've had the benefit of kind of growing up under. So I think it's great. And I think frankly, that's been a trend. I mean, everybody that I've seen at your level or close to your level can point to very specific people that, like, no, if it wasn't for this person and this space, so I think it's awesome that you're giving them recognition for that.
Well, thank you.
But yeah, VP of Infection Prevention. That's awesome. And I know we've only got a couple minutes here, but what's the overall scope of that? I mean, how big of a team are you over now?
So my team now is, I have maybe 5 direct reports, but then because the individuals that are the directors and senior leaders of the different facilities, then they may have their own teams below them. But
Gotcha.
and then it's a very heavily matrixed position. So there are individuals that they're not my direct reports, but I work closely with them. So for example, long-term care, they're not my direct reports, but I do have monthly meetings with the group, and we, make decisions and, come to consensus on what our policies are going to be as a group. And I am the leader, for those discussions. So overall, there are about 20 IPs that I'm really working with, but a smaller subset that are my own direct reports.
Gotcha. And then your day-to-day job now, has it turned to mostly all policy, or what does your day look like now compared to what just like a staff IP would be?
Yeah, right. I'm not doing so much surveillance. I'm not doing so much, applying the definitions. But I am overviewing policies, especially when there are policies that I feel need to evolve and move forward. And so we need to get the buy-in of the executive medical director of GI, for example, to look again at how we're managing our endoscopes. So it's sort of the policy work, but at I think a higher level. It's more about their persuasion and the influencing to be sure that we're truly following evidence-based practice as a system across multiple facilities.
Okay. All right.
Thank you for joining us on this episode of Voice for Infection Prevention. We hope you found our discussions informative and insightful. Remember to subscribe to our podcast for more conversations with experts in the field, and don't forget to leave us a review to let us know what you think. For additional resources and to stay updated on the latest news in infection prevention, visit our website at voiceforip.com. Thank you again for listening. Until next time, stay safe and continue your commitment to excellence in infection prevention.